scapula, make sure they're comfortable. Sometimes I'll even put a pillow up underneath their arm just to make sure they're in a position of comfort. And then I just use more of like a bracketed palpation. I just try to find like right there, a little tender. Okay, so I can do a couple different things. I can stabilize the scapula, I can use my thumb, and I can just lay into that. Is that reproducing pain down your arm at all?
Not so much down, just staying on the shoulder.
Localized. Okay, so pain tenders, and I'll flip them over on the other side and show the other side, but I'm just stabilizing and going after it. Okay, so don't be afraid, either using that or you can use your 2 fingers, go in there and it's just trigger point release. Slow sustained pressure, holding for 30 to 60 seconds. And what am I looking for? A change, right? I want to know that there's some sort of either decrease in that myofascial tightness, decrease in his symptoms, or hopefully both. And then I just follow that all the way down that posterior chain. So I'll start with infraspinatus and I'll treat that. Now I treat it a lot more with needling these days because that's a skill set that I have. It is totally appropriate to just go after it from a soft tissue release perspective. I think you do these patients a disservice if you're sitting there treating the pec and you totally ignore the posterior cuff. So just drop down the whole scapula, go down that lateral border. It teres major, it teres minor, hit lat, and then I can treat down that posterior chain, spend about 5 minutes of doing some trigger point release. And if I hit that in the pec, at least I freed up a lot of those soft tissue restrictions, and then I can get into some of my corrective exercises. Any questions about that from this side? Pretty straightforward.
Do you maintain on each muscle until they say like symptom release, or just until you feel it, or is there like a 30-second?
No. So I do both. Okay, so I palpate, try to find a good spot right about there. Yeah. Okay, lay into that a little bit. See what happens, what changes, any change in that at all?
Yeah.
Getting worse?
No.
Okay. You know, so a lot of times too, I'll ask for a pain rating if it's painful. You know, what's your pain rating now? Wait 30 seconds, see what changes. Am I applying a lot of pressure there? Okay, I'm not digging my body weight into it. I'm using my IP joint of my thumb as my leverage. Okay. So from there, once I get the infraspinatus, I can treat that up, drop down teres major, teres minor, lat, and just go right down that posterior chain. Okay, same type idea as we did with the pec. We're going to apply slow sustained pressure over a trigger point. What's a trigger point going to feel like? Throwing it out there without a knot, a rope. Think about like if I palpate along his infraspinatus, I should feel normal tissue under my hand. Oh, there we go. That was a good one. Yeah, there it is. I should, sorry. I should feel normal tissue, and then once I get to a trigger point, it's going to feel more like a rope band. And then that's exactly what I'm going to go after. And I try to gradually increase my pressure so the patient doesn't come up off the table. It depends on their tolerance a lot of times, but but it's really just an effective way to manage things. So you can do it that way. You can use tools. There's all kinds of pressure. Dr. Nichols